Hey there, everyone. Dr. Jess here. Sorry I'm a little late today. Technical difficulties, but we got it all working. So today I'm here to talk to you about myofascial pain syndrome. We are in the last week of October, so it's the last week of Breast Cancer Awareness Month. So this is a topic that is not just in relation to breast cancer, but it is something that is common within the population of individuals affected by breast cancer. Therefore, it's a good topic to kind of end the month with. All right. Now, what we're going to be focusing on today is myofascial pain syndrome. So, and within that, what are trigger points? How can therapy help? And then why does this correlate sometimes with shoulder pain? And so, this is more of our breast cancer specific conversation today. And when we're done with the talk, hopefully you'll learn a little bit more. All right. Now, myofascial pain syndrome is something that is simply means that we've got pain that's arising from trigger points that are located in some muscles, multiple muscles, maybe just a few muscles, just kind of depends on the individual. But nearly half of women develop myofascial pain syndrome within the first year of breast cancer surgery. So this is something that's pretty common in this population, and it's something that's very treatable. That's the biggest news to know. Now, as far as myofascial pain syndrome, it's specifically talking about individuals that develop trigger points. And so trigger points are top bands of fibers within the muscle. So, the muscle fibers, we should be able to kind of roll across, and it feels pretty consistent over that muscle. It's not like I'm rolling over the muscle and then I'm like bumping over something that's really tight. And it's like, what's going on there? So when we feel that and then we start to press into it and it's like, oh, wow, that's sore, that hurts. And then maybe that pain travels to a different location. That's what we call a trigger point. And so trigger points can be in any muscle in the body, and they can be what we call either active or latent. So an active trigger point is something that's referring pain all the time. So even when you're not using the muscle, the trigger point is actively referring pain. Versus a latent trigger point, that's a little bit different. So that one is not actively referring pain, so you're not even quite aware of it. But then all of a sudden, if you start to activate that muscle, or if you start to push on that muscle, and it's like, then you get pain from it. So those are the two, but both are still palpable when you're running your fingers through that muscle. Okay, so it's typically, it's that knot that you feel. All right, so what are common muscles affected after breast cancer surgery? So these are the muscles that we typically see. They're not the only ones that might be impacted. There's many more muscles that could be impacted. Every individual is different, but these are the ones that I like to talk about first because they're more common. So the subscapularis, this muscle sits on the front of the shoulder blade. So if I'm going to get to that muscle, I can get to it as far as a therapist was. I can get from 2 points. I can raise the arm up, and then I can try and get right. So here's the outside portion of my shoulder blade. I can feel that bony prominence. I can walk my fingers in and then push on the front of my shoulder blade there, okay? And so that is the muscle that is kind of helps with some of the shoulder motions with what we call internal rotation. And that muscle is really, really commonly impacted after breast cancer surgeries. Radiation fibrosis can affect kind of how everything's pulling on that area. And that muscle can refer pain into the back of the arm and then all the way even to the back of the wrist, which is interesting. So it's like this muscle's on the front of the shoulder blade, on the front of the shoulder blade itself, but you might be having soreness on the back of the shoulder from that. So it's like, that's interesting, because we start poking around back here and we're like, that doesn't really hurt me. And then I come into here and it's like, wow, that really makes my shoulder hurt. That's a trigger point. And so that's what we would need to treat. The pecs. So the pecs are in the front of your chest. The pec major is the one that we can kind of pinch and lift pretty easily. And so that one commonly gives pain into the front of the chest, but then it can also refer pain down the inside of the arm all the way down to the elbow. So sometimes this like kind of achiness, tenderness, soreness that's felt, that's not just isolated to this one specific spot in the pec. It can really kind of ooze and radiate. Rhomboids are along the shoulder blade. And so those muscles, typically with trigger points, they stay a little bit more local to right along that shoulder blade line. They don't refer out as much. But again, that's not comfortable when you're like, man, it's like, I just can't get away from this. It's like I sit, and it's like everything just, and back here is super achy and uncomfortable. So that could be the rhomboids that are flared up. The serratus anterior. This is a big one that I think is commonly undertreated, because when there's a whether it's a mastectomy, lumpectomy, lymph node dissection, there's commonly there's a sense of numbness in this area, but it's not numb that you can't actually feel pain. It's just the skin itself, the sensation to the skin feels less sensitive than it did before surgery. So it's like, but it feels numb, but it hurts. So people are like, how is that a thing? Well, the skin has decreased sensation, but the muscle underneath the skin is still giving you pain. And so this muscle is one that I find a lot of times is pretty flared up. Now this muscle attaches to the ribs, and so when we kind of feel into that rib cage, you can feel that that muscle might be referring some pain. So it might refer pain all over this area. It might refer pain down into the arm. There's a lot of different ways that this might present. It could also present into the back of the shoulder blade, which is kind of interesting. But it would be noticeable. Like we push the muscle, and it's like, woof, that is what causes that's that soreness that I've been feeling. We just need to treat that muscle. That's all. And then the pec minor is the pec that's deep to the pec major, so which means it's underneath the pec major. That one's a lot harder to get to yourself. You really have to kind of get under the pec major and then get into that pec minor. But that one really does get pretty tight in this population, and it's mainly because think of like the surgical area and then think of the radiated field. This muscle it just gets kind of tight and guarded, and it doesn't love everything that's been happening. So we free up the muscle, we free up the trigger points, and we can see a really significant decrease in pain and improved function. All right, so treatment approach. Like, what do we do about this? We don't just say, okay, they exist, so best of luck, goodbye. We want to come in and we want to do a full evaluation to understand, why are these trigger points here? Is there some sort of an abnormal movement pattern? Is there an abnormal habitual posture? Is there scar tissue that's not moving well? Are there joint mobility that's not where it should be? There's a lot of different things that create this abnormal scene, and then the muscle just goes into this guarded pattern, and we've got to create normalized mobility throughout, while we also then treat the trigger points that we find. So it's not as simple as just treating the trigger points. We've got to treat the trigger points and any of the abnormal biomechanics that are contributing to why the trigger point is persisting. So how we treat trigger points, many different ways, but we do a hands-on approach. And so we're going to get in there. We're going to do what we call an active release, where we kind of hold the pressure on that trigger point and ask you to contract the muscle. We might do a passive release, where we're just going to kind of hold some pressure, and then we're going to kind of like passively move your arm or passively move your shoulder blade and see if we can get that to relax. The other thing that we can do now is we can do some dry needling. So we can dry needle right into the trigger point, depending on where the trigger point's located and safety and whatnot. That's just another technique that we use to treat the trigger point. But like I said, it's not just treating the trigger points for treating myofascial pain syndrome. It's treating the symptom, which is the trigger point, but then also treating the cause to the situation, which is commonly, like I said, it's that kind of tighter pec on the more involved side, on the side that's been potentially radiated, the radiation of fibrosis. We've got some what we call hypomobility, or stiffness in the shoulder, hypomobility in where the shoulder blade and rib cage articulate, and then some weaknesses that develop as well. So then the shoulder blade starts to get a little bit weak, so you're not able to pull that shoulder blade back and sustain the posture like we'd like you to. So all of these things are what we're going to be doing to actually get the resolution of pain that what individuals are looking for. Is what I would be looking for. I don't want the short-term solution. I want the short-term and the long-term solution, so it doesn't come back. All right, now, so myofascial pain syndrome can very much lead into shoulder pain. And so, is shoulder pain after breast cancer treatment, is pain in the shoulder after breast cancer the new normal? And no, like, you should not continue to have pain in your shoulder after breast cancer. And there's evidence to support this. So if individuals, and big study that was done, individuals that were able to participate in physical therapy early on after surgery versus individuals that didn't. Okay, so if we go to a 5-year outcome, right? So we've got one individual that did physical therapy, one that didn't after breast cancer surgery. 5 years later, okay, the people that did nothing at all, 43% of those individuals continued to present with shoulder limitation, whereas 9% of the individuals that did participate in early intervention. So early intervention led to a significant decrease in long-term shoulder pain and decreased function, which is a big deal. It's something that we know. So let's get in there. Let's know that these things happen, and let's address them so that we don't have this long-term problem. All right, so, and again, and this is just like a little bit of a picture of the muscles themselves. So we can see that when we've got surgery and we've got muscles that might be guarded, that's going to affect the shoulder. We might have the joint that might be kind of tight and stiff. So we might have some what we call hypomobility in the joint. And then we've also have scar tissue that might prevent some of the normal mobility, in addition to some of the radiation fibrosis. So all of these things could be impacted and are commonly impacted after breast cancer treatment, whether it's surgery, radiation, and or chemo. A lot of different things can all kind of culminate as well. It's usually not just one. Now, how can physical therapy help? Well, now we're going to take that picture out and we're going to look at the whole shoulder itself, okay? So the whole shoulder is comprised of not only muscle, which has the trigger points in it, but then it's got joints and postural influence and what we call the scapulothoracic articulation. So treating the trigger point then leads into treating the whole shoulder, which then leads into overall improved shoulder function and decreased overall what we call disability or functional limitation. So recapping, biggest thing that we need to talk about and get the community of individuals that have been affected by breast cancer to understand is pain inevitable after breast cancer? And the answer is no, okay? Pain and decreased function is not something that needs to be just accepted as normal, and it's something that can be addressed by specialty trained therapists. So when we're thinking about this with this population with breast cancer, not all physical therapists are trained to understand the stresses that can happen to the lymphatic system, which we have to be very aware of. They're not all trained to really understand what kind of chemotherapies might have been introduced, what happens after radiation and during radiation, what kind of surgeries may have been done, whether it was reconstruction was done or not, what kind of reconstruction was performed. All of these things are things that you want your therapist, whoever you're working with, to really understand so they can treat you from an orthopedic perspective, but safely, but then have a good understanding of the lymphatic system so that they're not going to do anything that could potentially overstress that lymphatic system. So it's really about really finding that specialty trained therapist can most definitely help with any individual that's been affected by breast cancer and improve their pain and overall mobility. So the one thing that I like to also, oh, sorry, there's some more research I forgot I was going to tell you guys about. So the and I've got a list of all of my articles at the end as well, in case anybody who's ever interested in reading some of the research. But overall, increasing the functional mobility of individuals after breast cancer, it decreases the economic burden of cancer, okay, to both the survivor and to society. Because if we can get individuals feeling better, they're going to be more likely to be able to return to work or full-time work, okay, which allows them to be able to help with their household, okay? It also helps them to be able to take care of their house, so they can have better upkeep of their home. They can have better upkeep of themselves and not require assistance from individuals coming into their home to help them with things. So there's a lot that goes on with being, as far as the economic burden of cancer in our society. So we really want people feeling good enough to be able to kind of take back over their lives again, just like they had them before. The other thing that we see with early intervention is that we have decreased likelihood of an end-stage lymphedema, which is just the more progressed lymphedema that can happen after breast cancer. So the likelihood of that like more progressed stage decreases from 30% to 6% when early intervention was performed. And then there's also decreased prevalence of the ongoing shoulder pain, which we had just talked about, from 43% down to 9% with early intervention. And then we want to definitely treat the individuals, the 50% of individuals that are struggling with myofascial pain syndrome. We want to treat them and get them feeling better, because we know that there's a huge percentage of individuals out there affected by this. All right, now, questions, you can always leave some questions in the comments if you have some. You can also, did I leave my, oops, sorry, I did not. Maybe what we'll do in the comments is put my email in there. Sorry, I totally forgot to put my email address in there. But in the comments underneath, I'll be checking those later, and you can write some comments or questions in there. I'll definitely make sure I get back to you. And okay, and what else was I going to say? Oh, my email is Jess, Jess, at pptjax.com. You can check out our website. We've got some good information on the website as well. pptjax.com, and we'll go from there. Okay. And then this is just that list of articles in case anybody was interested. I can go ahead and send them over to you if you are a nerd like me and like to read articles. All right. So I'm happy to talk with you all today, and I hope you have a good rest of your Friday.